All right, so I'm Louis Streb. I'm the content enrichment specialist for the advanced med surge for Galen, for all of them. 265 is what I'm doing today. So if you're here for the BSM program, I'm going to do a separate one because it's just too confusing to me. I like to get in your book. This is the way I recommend everybody look at your book. Our exams come off of your learning objectives based on what NCLEX wants, and NCLEX cares about what? Patient safety, always. So what I always recommend is go into your syllabus, and I copy and paste right from your syllabus exactly what it says for chapter 57. We need to go through pages 1235 to 1245 only, and that's all I'm going to look at because there's no reason not to. It also has a chapter 33, which is weird because that's cardiovascular. I know that sounds kind of crazy, but it's the pheochromocytoma, which is what? It's an adrenal gland tumor. So I'm going to include it on here. I'm not going to pull up chapter 33 and go back into it. I literally just copy and pasted what it said on those pages and put it right here and here. So I'm not going to go back to a whole chapter for one page. It seems ridiculous to me. I know what I want to talk to you about in here, so I'll talk to you that in a minute when we're done. Okay, that's just how I figure is the best way for me to do this. That way you don't ever have to worry about what PowerPoint I use. You got the book, and you should have the resource where you can go on Evolve. Do y'all have the Evolve online book? You should. If you bought the regular book, you can register it, but I like it because you can make notes and it doesn't disappear. If you log in through any computer, it's always there for you. All right, here's where I always start. Even though this is not on our page numbers, once again, let me just show one more time. Page numbers are going to be 1235 to 1245. That's it. That's all we need you to know in this chapter. But I want you to start here. What we're going to talk about today with the pituitary gland and the adrenal gland, why do we care? Fluid and electrolyte balances. That's what it says. Your book tells us this is your priority concept. So everything we're going to talk about on some level will impact fluid and electrolyte balance. What does that even mean? I'll show you. Especially when we think about hypercortisolism or Cushing's disease. We're talking about Cushing is too much. So you have a hyper secretion of the adrenal gland itself. Why does that matter? Because it's going to impact immunity and it's going to talk about cellular regulation again. So I'm going to show you how these matter. I'm going to show you why the drugs matter and how you as a nurse have to think. So I'll start from the very get-go. Every time you look at anything in the book, I really want you to envision being at clinical, standing there with 6 patients and trying to figure out who do I see first, because that's exactly what the test questions are. They're going to give you information and you're going to have to figure out if that's normal or abnormal. Y'all, that's what your job is when you graduate. Every morning when I take shift change, I say, ooh, I have 6 patients. Who's my priority patient? And then when I figure out who I see first, I walk in their room and say, ooh, what is my priority? Intervention. Because that's what I do every single day for a living. So I should be pretty good at this, right? And you will be too when you get there. So I won't beat up a lot here. I put some stuff in here, this is my own thing. We're not even here. This is not what we're supposed to be yet, right? Because we're not at 1235 to 1245 yet. But I just think about the cellular regulation again and the fluid and electrolytes, and I start thinking about antidiuretic hormone, because that's what we're going to talk about very shortly. Antidiuretic hormone, meaning we can't pee. Vasopressin. Have y'all heard that word, that drug, vasopressin? Yeah. It's typically we use it in the ICU. Vasopressor, we give vasopressors. Vasopressor, that's an antidiuretic hormone, meaning what? Retaining fluid. Electrolyte balance, fluid balance, that's all we're talking about here, truly. So when you start thinking about patients and senses of things you understand, do you treat any of these diseases as nurses? No, but you understand fluid volume overload and you understand fluid volume deficit. And it's the same nursing interventions regardless of the cause. Fluid volume overload is fluid volume overload. I don't have to memorize everything. I know it just because I've known it for the other diseases. That's where I want you to start thinking. So I'm going to skip all of this. As painful as it might be to script through your book, you need to get where it starts. And it says start here with diabetes insipidus. So I know we're not going over the stuff you should know already, but quick breakdown. The pituitary gland sits right up here in your brain, right? And the pituitary gland has an anterior and a posterior pituitary gland. The posterior pituitary gland is directly involved in the secretion of antidiuretic hormone. So the anterior portion of the pituitary gland typically releases hormones to act on other organs or glands to release other hormones, right? Versus here, It's your posterior pituitary gland. If it's messed up, if you have head injury or a head trauma, if you have increased intracranial pressure, it's going to impact your ability to secrete enough ADH or not enough ADH. So that's what diabetes insipidus is. So diabetes insipidus is too much, right? Too much of too little. My good, y'all, I'm trying to screw myself up here. Diabetes insipidus, I think about diabetes insipidus in the most weird term. When I think about diabetes insipidus, I think about, and it's going to be horrible sounding, a regular diabetic who pees a lot. Fluid volume deficit, anti-diuretic hormone. If I have anti-diuretic hormone, that means I'm not supposed to pee. And if I have fluid, so what do you think? What do you think diabetes insipidus is? Is it too little or too less? Any of y'all know? It's a hard one, right? Yeah. So think about syndrome. Go on the flip side. Is somebody talking?
I was going to say diabetes insipidus. Wouldn't it be like too much of the hormone? So that's why they're losing a lot of fluid.
So if you have anti-diuretic hormones be a vasopressor. It makes you not pee. So if I have diabetes insipidus, I like to think, oh, I'm peeing too much, so I don't have enough anti-diuretic hormone. This is a hyposecretion of your anti-diuretic hormone. Does that make sense? So the result of DI is excretion of large amounts of water. It's your kidneys can't reabsorb all this stuff. They can't reabsorb the water. So that's the polyuria portion, right? The excessive water loss. That's why when I think diabetes insipidus, that's why I make that correlation, right? Because diabetes, polyuria, if you're peeing everything out, if you're peeing too much, that means you have not enough fluid. You're in what? Fluid volume deficit. So what do we do for everybody in fluid volume deficit? Replace the fluid. That's it. Always give them more fluid. So this is a hyposecretion. That's what I want you to understand. If you can make that correlation, now SIADH is just the opposite. It's everything opposite of this. So massive water loss. It also increases things like your plasma osmolarity. What is plasma osmolarity? It's just all the stuff in your blood. It's the sodium. It's the chloride. It's just the particles. So if I pee out all of my water, right, it's going to increase what is left over. My plasma osmolarity will be higher. All of those things look like they're more because I just got rid of all of my fluid. You ever take a tablespoon of water and put it in a cup when you have like a sore throat and you gargle it and it's kind of gross, right? You wouldn't want to do that every day because it's a small amount of water. And imagine you put a teaspoon or a tablespoon of water in a pot of pasta when you're cooking spaghetti. You can't even taste it that much because of that dilution. That's all we're saying here. So water loss increases the plasma osmolarity. It's all of these things here. That's all. You don't have to memorize that. I just want you to get an understanding before we kind of move forward. So what do you think we're going to worry about? What are our primary interventions? What are we talking about with these patients? Is that these patients are in fluid volume deficit. So action alert, ensure that no patient suspected of DI is deprived of fluids for more than 4 hours because they can result in acute kidney injury. That's why all of these things are related. So think about Cushing, think about your safety boxes. This is where nurses have to think. There are different causes of diabetes insipidus. Like I said, you could have a cause where your pituitary gland is just, it got injured. Or you could have something secondary caused by something else that impacts the pituitary gland. We don't really get into that all that much. It could be a brain surgery, it could be a tumor, a head trauma. We don't, like I said, we don't get into that a whole lot. But there are drug-related diabetes insipidus causes like lithium. This is not a true, it could be not a true cause. This would be where they drink too much water. So if you take in lithium, you might drink so much water that it causes you to have that fluid volume on the other side. So we'll talk about that a little later on. I just want you to understand that lithium can cause problems as well. So move through that and not worry too much. What do we need to know as nurses? So assessment is the first step in the nursing process. Always. I assure you, the majority of your test questions are going to be based on you're developing a plan of care. You walk into a patient's room. It's going to give you a background, and they're going to give you assessment data as well. They're going to talk about you're receiving this medication or whatever. They're always going to set a picture that's going to include assessment data. I'm not saying you have to know 100% all this stuff, but when you think about a patient who's peeing, we're talking about excessive amounts. they're peeing out 4 to 30 liters of water a day. How much water do y'all drink a day? I'm sure it's not even 4 liters. That's 16 cups of water. Could you imagine just peeing out 4 liters? Now pee out 120 cups of water. Oh my God. I mean, you're going to be so emaciated. That is going to lower your specific gravity. It's going to lower, so low osmolality. Certain things can happen. It just depends on what is going on with these patients. I just want you to be aware. You never know what kind of test questions you're going to get or what they're going to have up in there. We don't really focus on these kind of things here, but they're always going to be in the stem of the question. And if you don't know what those are, it really makes it hard for you to want to answer a question correctly because you get scared. All right, so that's some of the assessment data. We kind of know what we're going to be looking for. We know what fluid volume overload looks like regardless. It looks like shock from fluid overload. You know what that looks like. Crackles, distended neck veins, things like that. That's what, I'm not on this one. This is fluid volume deficit. So on this one, it's going to look totally different. You're going to be emaciated, things of that nature. So what can we do about it? Some of the drugs we're going to give is the big thing. We're going to give you a vasopressin. That's what we're going to do. So you might have to go to the ICU. We'll give you vasopressin, and it causes you to have some of the antidiuretic. It replaces the antidiuretic hormone. It decreases your urination. It lets you kind of keep in the fluid. It's a sublingual. I just put the things I know about it, right? So these types of patients who have mild diabetes insipidus will usually be on this for a couple of doses, and and they kind of move on from there. But it's important for you to teach them that an extra dose of that medication may very well be indicated if your thirst starts to increase, if your urination starts to increase, right? This is going back to medication. I'm not asking you to memorize medications. I'm saying for each disease process, you need to know what your job as a nurse is. It is to assess, is to know what interventions are really working. Because if your doctor, if the physician who is assigned to this patient doesn't order the medication they need, it is your responsibility as well to call the physician and say, hey, physician, my patient is in need of this medication because they're in fluid volume deficit and they need something to kind of help them. So just keep that in mind. Like I said, vasopressins are what we're going to work and what we're going to use and kind of go from there. Key features, we can think about a hypotension, tachycardia. Those are signs and symptoms of what? Fluid volume deficit. We already know what shock looks like. Cardiac output equals heart rate times stroke volume. If I lose my volume, what has to go up? My heart rate. There's no other way around that. So this is when we start thinking about that patho portion of life. This is where nurses have to really understand why and not just that it happens. You need to know the why, because the why lets you know all of these signs and symptoms without ever having to memorize them. It just starts to make sense. Increase urine output. Yeah, okay. I don't have any antidiuretic hormone. Dilute, low specific gravity. You're right, because I'm peeing everything out, so I'm just retaining all of the byproducts. Bad skin turgor. Every one of these look like fluid volume deficit. You can see how I kind of move through stuff a little bit, right? It's not too imperative that you spend all your time trying to figure that out. All right, so if we keep moving down from there, diabetes insipidus is a hyposecretion of antidiuretic hormone, meaning we need more antidiuretic hormone. If you get down here to this syndrome of inappropriate antidiuretic hormone, this one is fluid volume overload. This is jugular vein distension. This is fluid in your lungs, right? Fluid volume overload always looks and sounds the same, y'all, because where's the fluid going to go? It doesn't matter what the cause is, it still goes to the same location. So when I think about inappropriate amounts of anything, if you got an inappropriate amount of something, that means you got too much of it, correct, typically? Yeah, that's the way I remember it. I'm like, oh my God, if you're inappropriate, you probably went overboard. You overdid it. So I think this way from my own brain, because y'all, I get screwed up on DI and SIADH. I know what both of them are, but on an exam, it's easy to flip it around in your mind and think overload versus deficit. Do y'all encounter that sometimes? Yeah, I know I do. All right, so we know this, water retention, fluid volume overload, cool. It's just the opposite. Now your plasma osmolarity may be normal or decreased, right? And it inhibits ADH production and secretion. So a decrease in your plasma osmolarity, this should make sense. If my plasma has a decreased osmolarity, that means I have too much fluid because it's diluted. So my body is going to be like, you need to pee some of this stuff out to get your plasma osmolarity back to normal. That's how the body works. Everything is a compensatory mechanism. It works to get to homeostasis. Once you realize that your body's only secreting something to make something else more normal, it starts making sense. So here we go. If I have too much diuretic hormone, it starts making sense. All right. Dilutional hyponatremia is a big thing as well. What does that mean? If I have too much fluid in my body, the sodium didn't increase, it didn't decrease, it just got diluted. So you will see decreased serum levels in fluid volume overload. And we know that increase in blood volume also increases the kidney filtration and inhibits the release of renin and aldosterone. And we'll talk about aldosterone because that increases urine sodium loss and results in greater hyponatremia. So it just becomes more and more problematic. It goes from bad to worse and your body does it. So much so that it's not abnormal to see the serum levels go down to like 115. What's a normal sodium level? Do you remember?
135 to 145.
Yeah, 135 to 145, absolutely. So when you see them getting this low, it's very problematic. But it's water retention, hyponatremia, fluid shifts, right, from the central circulating system over into the interstitial, or from the interstitial into the circulatory system, right? Because now you're anti-diuretic, you get inappropriate amounts, and then now you're kind of holding on there. No, you're third spacing. Yes, my God. So you start to dilute. Yeah, it's an interesting thought. So water retention causes urine volume to decrease. That makes sense. Urine osmolarity starts to increase now because it starts to get diluted. I just want you to see the cause and effect if you start understanding this. So what do you do? If somebody's in fluid volume overload, what is your priority intervention? Stop fluid volume overload. So don't give any more fluids. Restrict it greatly. It could be as little as 500 cc's a day. I mean, literally, fluid intake can be kept as low as 500 to 1,000 mLs. Y'all, that is 2 cups to 4 cups a day. Some of you are like, that's all I drink anyway. I get it, but we're talking about you ain't drinking nothing else. No sodas, no milk, nothing. So that's all you get. That's hard. So we have to think about things like this. If we can't give fluids, sometimes we have to use maybe not water, but we'll use like normal saline or something like that instead if we're flushing GI tubes or anything of that nature, because we don't want to put you in further fluid volume overload. And if we give you sodium, it's going to help with the dilutional hyponatremia. So, all right, you're not learning anything crazy yet. I promise you. I'm just going over basic stuff so you can make sure you get it. I's and O's, daily weights. There's always a confusion about that. Daily weights are your greatest, most effective way of understanding if somebody's in fluid volume overload. You know how I know this? Because 1 kilogram equals what? 1 kilogram equals 1 liter of fluid. If I gain 2 kilograms of weight, I gain 2 liters of fluid. It is that simple, y'all. So if you gain 3 kilograms, or 1 kilogram, 2.2 pounds, it equals 1,000 mLs of retention. Isn't that kind of cool? I like that. So when we have a 1 kilogram or 2.2 pounds in one day, or a gradual increase over several days, that's when it's problematic. I just want to put that out there for you. That doesn't mean that a priority intervention can't be I's and O's, because I assure you, one of your priority interventions is I's and O's. You need strict I's and O's to make sure they're not getting more than that 500. So they're not one and the same, but they're not mutually exclusive of each other as well. The gold standard for fluid volume, it would be that daily weight, same time, same location, same clothes, same scale, every single day. Yeah. So I just want you to understand the difference there, because those always pop on exams, do they not? So that was it. That is all you have to know with your anti-diuretic hormones. Truly, know the causes, know what they might present with, what might be a reason for them to be in diabetes insipidus. Like I always tell you, head trauma is a big one. Intracranial pressure, those always kind of pop up. You can go back and look at your book. It's got all kinds of information on these type of patients and what it looks like. And then for your syndrome of inappropriate anti-diuretic hormone, it could be very well just something not so sinister. It could be a decrease in your osmolarity due to something else, fluid volume, over whatever. It could be heart failure. There's a lot of reasons it can lead you to stuff. I'm not trying to get into that. I just want you to know what to look out for. things that are going to kill your patient. That's what we're going to test you over. All right. So now going to the adrenal gland. So where is the adrenal gland located? Do you know which organ is on top of?
The kidneys.
Yeah. And what does it secrete? It's a loaded question. It's a lot of things.
It's oh, we just went over it. I'm pretty sure calcitonin. No, I might be mixing it with something else. I can't remember right in a second.
Okay. I always say salt, sugar, sex, and steroids.
I was gonna say that, but
Yeah.
I didn't
Sounds
know
like a
which one,
fun,
the specific
weekend,
thing.
right? Salt, sugar, sex, and steroids. I know it's probably a bad joke, but we got to make light of what we do for a living. Yeah. So I think about those kinds of things: salt, sugar, glucocorticoids, right? Steroids, the prednisones and glucocorticoids. I just keep saying it over and over again. So I don't try to get too crazy with it, but that's what we're looking at. So when we think about somebody who has an adrenal gland, we know that when something happens in life, fight or flight, right? Something like that happens, your brain, the pituitary gland, the anterior pituitary says, ooh, we should send ACTH, which is adrenocorticotropic hormone, right? That's secreted by your pituitary gland. And it goes to the adrenal cortex and says, all right, you need to secrete salt, sugar, sex. What? All the things that are part of that. So we get down here. We know that when you have inefficient amounts of adrenal corticosteroids, so this is a hypofunction, your adrenal gland is not secreting enough salt, sugar, sex, steroid type hormones. It results in the problems. It causes a loss of aldosterone and cortisol. And we're going to look at these. Decreased cortisol levels result in hypoglycemia. So this is that salt, sugar, sex, steroid part. Cortisol levels, and that's probably the word you were trying to say a minute ago, right? Or did you say cortisol? I think you said something else.
I was not trying to say the calcium. I was mixing it with thyroid in my head.
That's okay.
But salt, sugar, sex was in my head. I just couldn't remember how to say cortisol.
You don't have to. So now say it in the way that makes sense to you. I never say cortisol. I say salt, sugar, sex, steroids. And I go back and I look for anything that looks like salt, sugar, sex, or steroids. I swear to you. That's how my mind works. I'm recording this. I don't mind saying that because we're all the same, y'all. You have to memorize it in a way that makes sense to you. So do that. What are we talking about? The cortisol level. So hypoglycemia. Your patient, if they are a hypofunction of salt, sugar, steroids, that means they're going to have a decreased salt, hyponatremia, a decreased sugar, hypoglycemia. It just starts making sense. The signs and symptoms are out there. So I just think about that loss of aldosterone and the cortisol and how that's going to impact the body. I'll show you. Reduced aldosterone secretion causes disturbances in fluid electrolyte. Potassium excretion is decreased, causing hyperkalemia. So this is what I mean when we say fluid and electrolytes. Your book tells you what you need to know. Sometimes you're like, I don't even understand what you're talking about, Mr. Trevor. How is fluid and electrolyte? This is what your book is saying. So why do we care about potassium excretion? What happens in hyperkalemia? You have dysrhythmias and you die of a heart attack. So that's why we care. Literally, if you have hypo secretion of the adrenal gland, and we'll talk about this in a minute. So when I think about that, I think about what? Addison's disease, Addisonian crisis. I think add Addison's, add salt, add sugar, I don't want to say add sex because that's kind of weird, add steroids, right? If you think about those three S's, that's what you're going to add back in. That is the treatment plan. And that's what everything you're going to do is focus on. Add Addison's. Cushing, you got a Cushing, you need to decrease some. So they're just the opposite. Once you get one down, it's not so problematic. Severe hypotension results from the blood volume depletion that occurs with the loss of aldosterone, because we know that, once again, aldosterone in the kidneys and the reabsorption, we've already talked about this. So I need you to be wary of things like ordering a dietary consult. We have to think about not just sugar, so hypoglycemia things. We have to think about that. We also have to think about hyperkalemia, so foods that are high in potassium. We got sodium issues. So all of these things become a dietary consult. Not that you have to know what to order or anything, but you know that you have to reach out and do interdisciplinary type actions in order for your patient to get better. That's thinking like a nurse. I don't know what your teacher talks about in class because that's not what I'm focused on, but I know what they talk about is part of this. And I'm just trying to refocus on the things that are important, that I know to be important in my own thing. So hormone replacements, what you're going to do. If I need to add, what are we going to add? We're going to start rapid infusions of normal saline. So we need to add what? Salt or dextrose, sugar. Y'all, it's right there in the wording. I mean, if you understand what the disease is, I don't ever care about a medical diagnosis because I never treat a medical diagnosis. The reason I care about a medical diagnosis is because it clues me in to, oh, this is what the patient's going to present with, and these are the signs and symptoms. I know we're moving away from nursing diagnoses, right? That's kind of an old thing. We're moving away from those. We're not going to have NANDA before too long, but we're still focusing on the same thing. I will never treat Addison's disease. The physician will, but I will treat all the signs and symptoms as I wait for the physician to give me the stuff that I need to do the rest of my job that they didn't give me already. So does that start to make sense? Right? Interventions are initiated promptly, sodium levels fall, potassium levels rise rapidly if we don't do that. So that's problematic. Administer insulin, because we're talking about two things. You're like, Mr. Steb, we got hypoglycemia, right? We do, but we also know that administering insulin in equal parts to dextrose, so we're not trying to cause your blood sugar to go down or up here. We're just trying to get that shift of potassium into the cells, because we also know that insulin, not only does it bring glucose in the cells, but it also brings potassium in the cell. If you didn't know that, you should. It probably would have helped you better on your renal exam, correct? Because these are those connections. Everything happens together in unison. Nothing's in a vacuum. So insulin will be given, but not insulin to take your blood sugar down. That's why we have to give blood sugar still, because we're trying to increase it. Yeah, it starts making sense. I should make a note over here for that one. So I would, so if this was me, I'd go ahead and copy this one like this. I'm going to copy. I'm going to hit this bad boy right there, add a note, and I'm just going to copy and paste, because that is something for me that just makes sense. That sounds very much so like something I need to be aware of. Also, we're going to give thiazide diuretic, loop diuretics. What are those? Those are potassium what? They're not potassium sparing. We're supposed to avoid those. Those are potassium wasting. Because why? Because we already have hyperkalemia. This starts making sense. I know it's easier when I'm sitting there telling you about it and you're reading the books. You're like, oh my God, there's so many words, and you just start reading. This is what I'm going to do every single week. I'm just going to take down the chapter. I'm going to break it down. So if this helps you, keep coming back. It can't hurt you. I assure you that, because I already know the kind of test questions that we always ask, because I know what NCLEX wants. Trust me on this one. All right. So now you know some of the things there with hyposecretion of the adrenal gland. So this is called Addison's disease or Addisonian crisis. Yeah, there's a little difference there, but we can kind of debate that later on. It's not going to beat us up right now. You can go down the assessment. A lot of it looks the same. There are going to be some changes in skin. You can go back and look at those a little bit as well. The ones I really think about, though, trust me on this one, adrenal insufficiency, I think about muscle weakness. Why? Because it puts you at risk for falls. I always have to worry about that. That is always at the top of my list. So I know if you don't have enough salt, sugar, sex, steroids, it's going to make you hypovolemic as well. It's going to cause problems with your muscle weakness, and it's going to make you fall, and it's going to make you hypotensive. And all of these things I have to start worrying about, so my patient can fall. Yeah, you just have to kind of go back and read a little bit, and not read just to read all the words, but kind of focus on physical assessment. You can go through here and just kind of, and I didn't highlight everything on purpose, because am I going to look at all this? Probably not. I look at it. There's some stimulating the hormone. We talked about that a little bit earlier. Yeah, I can move on from there. Assess for hypoglycemia. You should know signs and symptoms of hypoglycemia. If you don't, because you forgot and you just memorize and data dump, it's okay. If you don't know what things look like, how are you going to get them right on the exam? You can't. If they say your patient has hyperkalemia, they're hypokalemic, or they might just say your patient's diaphoretic, has headache, tachycardia, and tremors, a potassium level of 5.4, heart. These are signs and symptoms that you're supposed to be like, oh, okay, that's what is probably the cause of this. So you can start treating what you can treat. And the rest of it kind of makes sense. I won't keep hitting it. Yeah. Why do I care about that one? Because you could fall and die. That always makes me a little bit scared. So the test, you can go back and look at these as well. They're opposite. Whatever one is, the other one has to be the opposite. So sodium, if we're thinking about a hypofunction, we quit saying like Addison's and Cushing's because it confused people. But when I think hypofunction, I think Addison's. Hypo, I need to add more. So I'm going to have low sodium. I'm going to have low glucose because salt, sugar, right? Low steroids, cortisol are steroids. They're all low. Addison's hyperfunction, I need to add, Cushing's See, I can get myself confused. Hyperfunction, Cushing's, I have too much salt, I have too much sugar, I have too much steroids. It starts making sense when you look at it from that direction. So don't memorize, just learn what it is. So you can just keep going on and look, and there's it talks about so much: cortisol, aldosterone deficiencies, what they look like. I don't get into them because we don't really have to think too much, but like hydrocortisone corrects I can't say that, glucocorticoid deficiency. So it shouldn't be surprising if we give hydrocortisone. Is there another name for hydrocortisone? Do y'all remember that? This is why I like using the book. So I know what it is, but let's copy it. And let's pull up right here and let's copy and paste it. And let's figure out what the other name is. Cortisol creams, cortisol, there's all kinds of stuff. Any other names you've heard of before? I'm just looking through. All right. No worries. Just asking. You ever heard prednisone? Kind of in that same vein there. So it's easy to try and get confused on stuff. So I just want you to start looking as well. It's okay to not know all the answers. Go back and look. That's what we're supposed to do, right? So prednisone is one of those things we might have to consider giving the patient who has insufficiencies of the adrenal cortex. So you have Addison's disease. Yeah. It's fun. Oral corticosteroid replacements, they vary, blah, blah, blah. If you need to go back in there, I don't know that we're going to talk about this, but the most common drug used for this purpose is prednisone. It's right there for you. Divide it up, 2/3 given in the morning and the last third at 6 o'clock at night. I don't know. Those pop up all the time, y'all. I've seen it on ATI before. It shows up on NCLEX because it's a drug that you might be responsible for. Yeah. So I just put it out there. That's really all you have to know about that portion of this chapter. If we go down just a little bit more, the last part is going to be a hypercortisolism, right? Or hyper secretion of the adrenal gland, whatever you want to call that. It's kind of one and the same. It's not 100% the same, but close enough. We call that Cushing's disease. For me, Mr. Streb has to say Cushing's with a hyper, and I have to say Addison's with a hypo. It just makes sense to me. Even if it's not all the time correct, for my brain, it just works. So this problem is the adrenal cortex itself, meaning that the gland is having a problem. It could be some of the anterior pituitary gland as well. If it's not secreting, it could be the hypothalamus problem. But either way, the most often the times that we see a patient who goes into Cushing's disease is because they have hypercortisolism and it's glucocorticoid treatments. So we're going to talk about that. Most people who have Cushing's disease is because they were on a long-term glucocorticoid therapy. Isn't that an assessment question? Trust me, that's what NCLEX cares about, because when the patient comes in and they have a history, your eyes should be like, oh my Lord, I know what you might have. That's what doctors do. They're not any smarter than you and I. They just sat in school for about 6 times longer. So they heard the same stuff over and over and over and over and over. Same reason I know more than you do. I've done this over and over and over. You get really good at something the more you do it. Imagine that. It's like hiring somebody to put new carpet in your house. You want them to have experience. Same with nurses. So if you know that, start looking at things that might pop up on a test question. And when I say a test question, I mean real live patients in your room. That's a test question. Every time I walk in a room, I'm like, this is NCLEX all over again. They said, you could die. I don't get a second chance. All right. So the presence of excess glucocorticoids, regardless of the cause, affects your metabolism. We know that because it causes your body fat to go up. It causes a slow turnover of the fatty acids, meaning you don't burn them off correctly, right? When you have too much glucocorticoids, it causes your body to start storing fat and redistribute them in weird places. So that's why people who have Cushing's disease will have truncal obesity. Not distributed obesity, but truncal obesity. That could be a cause of hypercortisolism. That buffalo hump, on your back, distribution of fatty in the moon face where it starts to be swollen and round. You've heard all of those before. I'm not saying they're going to be a test question. As a matter of fact, there will never be a test question, like an answer on your exam. You're way past that. But they might show up as, you know, part of the assessment data in the stem of the question that leads you to believe, hypercortisolism. There's only a few things I can do about that. You start seeing the connection there. That we don't want you to memorize that stuff. We want you to know it so you can look at the patient and then understand what to do. Here's some great pictures if you want to see how the distribution is there, but you can see the skinny extremities and more of the truncal obesity there in the distribution of the fat pockets in undesirable or not common places. So high levels of corticosteroids. So we're talking about high levels of a few things, right? We talked about high levels of glucose. What's glucose? Sugar. That's all it is. I kind of want to talk about those words, and then we go down here and we think about high levels of corticosteroids. It's just steroids. So all of these are the salt, the sugar, and the steroids. This reduces production of your lymphocytes, which screws up your immune system. It also causes your spleen to shrink. And we know that your spleen is all about filtrating blood that comes out of the heart, right? That's what it does. The lymph system also filters out any impurities. So if you know that high corticosteroids that are high levels, that's what they cause. That's why when we have patients who have like lupus and they're on what kind of medication? Long-term corticosteroids. What are they at risk for? All kinds of inflammatory process issues and all kinds of infection. It's no different here, y'all. That's why if you go all the way back to the top of this section, it talked about what? Immunity. I promise you, the book tells you exactly what you should focus on. And when you're done reading the book, if you can't answer those top parts, you didn't read it right. You need to understand how it affects how it impacts infection, because now you can start thinking about any patient who walks into your room who has excess cortisol. You're like, I ain't the smartest person in the room, but I know you're at risk for infection and I need to do something about that. And at least that's my expectation. When you take care of one of my kids, I expect your brain to say, boom, and start going. Because let's not lie, both of y'all expect me to do the same thing if I take care of your loved one. And that's what you should be learning to learn like that. Passing nursing school and becoming a nurse, not exactly the same. There's a difference on passing an exam and there's a difference on learning nursing. But when you learn how to nurse, the exams are not that hard. I'm going to help you with that. All right. So I'm just thinking about this. Your pituitary gland oversecretes your ACTH. Cool. It causes that hormone causes hyperplasia in the adrenal cortex and both the adrenal gland, and it has an excess in glucocortical productions. So we already know that these things start kind of going together. That's what cortisol, that's how this happens. It's that oversecretion of the ACTH can cause this to be a problem. Brain tumors, things like that. So if you have a pituitary tumor, that you could do a transphenoidal hypophysectomy. That's something they do. We'll talk about that later, unless it was in 242 or 170. I have to think about my classes. But if we think about somebody who has a tumor, an adrenal carcinoma or an adrenal adenoma, right? We're talking about a tumor on top of your adrenal gland. I think of, we can go back to the very top here, pheochromocytoma. Right? A pheochromocytoma, that's a dysfunction of the adrenal medulla or the adrenal cortex. It causes secondary hypertension. Adrenal mediated hypertension is called, it talks about aldosterone and cortisol, all the things we talked about, your catecholamines, your epi, your norepi. The primary aldosterone, so we talk about excessive amounts of aldosterone, and that causes that hypertension. And since we have too much, we have hypokalemia. You don't have to get into all that. I just want you to be aware of these type of things, because if you have a tumor on your adrenal gland, it's going to cause problems. So I'm bringing that back up there. We worry about things that are related to Cushing's, like excessive body functions, like high respirations and high temperature and high blood pressure because of the aldosterone. It starts making sense. And what they'll do for that is cut it out, basically. They'll go in and do a removal of your tumor, and we have some problems with that as well. So if you think about somebody who has pheochromocytoma, things I want you to think about: instruct the patient to avoid excess bending coughing, increasing their pressure. You don't want to overexcite and create, you already have a patient who has this aldosterone issue that is causing hypertension. The last thing you want to do is increase pressure in your brain, because we call that a hemorrhagic stroke when it pops. Seriously, that's what we're trying to think about here. Frequently monitor the patient's blood pressure. Why? Because we're trying to avoid that pop and kill of our patient. So there you go. I went back and covered chapter 33 for you in the weirdest way possible. I'm gonna move that down here for the next time I do that lecture. But you see how they all tie in together? I don't even try to insult your intelligence. Y'all are smart people. You're here because you believe, and because you need to be here, because you deserve to be here. I'm just trying to help you figure out the best way to get through this. All right, so that's where we're at. We're here at Cushing's. We have too much salt, sugar, sex, and steroids. We know what that looks like now. We know what we have to do with it. So when we think about, there are different causes of Cushing's disease. I'm not going to get into it right now. It doesn't seem to be all that important at this moment. If your teacher covered it, definitely go back and look at it. But what are we talking about? Assessment, history, that's all part of it. Ask the patient, have they been on any kind of glucocorticoid drug therapy? Because we know that anybody who's been on these for multiple years, things like arthritis, RA, things like that, it's the first thing that comes to mind, that or something like lupus. Y'all, it puts them at risk for all of these signs and symptoms down here, because that's what hypercortisolism is. It doesn't have to be Cushing's disease, right? Hypercortisolism, if I give you too much cortisol, it's going to cause these problems. Moon face, buffalo hump, the weight gain, we start talking about that already. So priority nursing interventions. Eyes and nose. I definitely want to make sure I'm looking at your eyes and nose. If it said, what is the best thing? It would be daily weights, right? So we're really trying to figure out what the questions are asking you. Think about hypertension because of the fluid volume overload. If there's too much salt, what follows salt? Fluid. So we're already going to naturally have too much volume. And then with the aldosterone, that's also going to increase it because we can't excrete urine, so it just increases it more. It's an interesting thought, and I'll be honest with you. My first 10 years of nursing, I didn't know any of this stuff. I was just like, I graduated. I was taking care of patients. I was like, sure. I knew what I was doing. I didn't know why I was doing it. I didn't know what to look for. I'd be the first person to tell you that. I didn't feel like I was prepared out of nursing school to do my job. I mean, NCLEX said I was smart enough not to kill patients, and I guess that's really all you can expect from a patient, from a new nurse. But I don't want y'all to be like me the first few years. I don't want you to feel so overwhelmed that you hate your job. And I didn't like it that much. I was like, oh my God. But I was a nurse in the Navy and I was going to retire one way or the other. So if you start thinking this way, it's not near as hard when you start associating every disease with just signs and symptoms. You can treat fluid volume overload all the time. You know what sodium brings. If you have too much sodium, it's going to bring what? Some fluid volume overload. It is. And we've already talked about the risk for infections and reduced immunity because of the spleen, right? Go back. If you need to go back and listen to this again, think how high cortisol levels shrink your organs, specifically your spleen and your lymph nodes, and how these cytokine productions decrease. So you don't even have that, and it decreases your risk. It increases your risk for infection. So these patients got all kinds of potential nursing diagnoses. Once you realize that, it makes it easier to figure out what you need to do. So I'll say the same thing here, the changes in fat distribution, they can be on your neck. You see those things. I just like to show you. You can look at skin changes, cardiac. Go back and think about cardiac and how it reflects or how it impacts this, because that's important. Sodium and water reabsorption and retained. That's what we said. Sodium and water are reabsorbed and retained, leading to hypervolemia and edema formation, elevated blood pressure. Pulses are full and bounding, because that's what you expect anytime somebody has too much volume. We keep saying the same things over. Guess what's going to happen? You're going to believe it. You're not going to question your mind. You're just going to be on the test and be like, I believe it. I believe I can pass. I don't know. I'm just singing some, that's R. Kelly. I can't sing R. Kelly. Oh, Lord. I probably just violated FERPA or something. So we definitely want to make sure we're focusing on that kind of stuff. There's a few more things I want you to get into. Go down and look at nutrition therapy. I skipped a lot. You can go back and read this. Interventions are important. Patient safety. I've already talked about patient safety. You should already know that pulmonary edema is a big thing, right? Because what happens to any fluid? Fluid always third spaces. If you're in fluid volume overload, I don't care what the cause is. It's always going to go from intravascular to interstitial. If it's in my Intervascular in my pulmonary vascular system, it goes right into the alveolar spaces. So what am I worried about? Gas exchange, it's always the same, y'all. Whatever's going to kill my patient the fastest. It could be increased neck vein distension, because guess what happens? The left side of heart failure leads to right side of heart failure. Lung crackles, increase in peripheral edema, reduced urine output. Y'all, these are things you have to know. It just makes sense. And if it doesn't, then after you go back and read it and stuff and you attend these lectures, come back, book with me an individual appointment so we can go one-on-one and you can ask your questions in private and we can really just tailor it to what you need. So go back and think about some drug therapies. What are you going to have to give them? Stuff. So drug therapies involve interfering with this ACTH. We don't need your anterior pituitary gland pumping out more ACTH, telling the adrenal gland to give us more salt, sugar, sex, and steroids, because we already have Cushing's disease. We have a Cushing of that. We don't need no more. So the drug therapy we're going to give you is going to be designed to reduce that. That's kind of cool. So there are different drugs. You can kind of look at that, but go back and look at some of the different drugs in there. I don't know what your test question is going to ask you. I have no idea what they're going to ask you right away because it changes all the time. But think about how certain drugs, at least know names. So you're never too in the weeds. All right, nutritional therapy, sodium restriction, too much salt, sugar, sex, salt, sugar, steroids, right? So think about that. Think about glucose. It's good to know that no sugar added is cool and all, but make sure you talk to the experts, get that nutritional education, get a dietitian to come talk. They need to think and figure out, is it 2 grams a day to 4 grams? That's not for me to decide, y'all. That's for somebody who's outside of my scope of practice. That's a dietitian, physician. That is not a me thing, right? I've already talked about this right here. Each pound of weight gained equals 500 mLs. I said that 2.2 equals a liter. You kind of get it here. Make sure you understand that you have to weigh every day before breakfast. Exact same thing. So much here that I even said it. Monitor eyes and nose. That is a priority intervention. Daily weights, best indicator. Prevent infection. Why? Oh, that's right, because my patient now is going to have a problem with the spleen in the lymphatic system starting to decrease. So they're going to be a risk for infection. So now I have to think about putting my patient on maybe even a reverse isolation sometimes, where people who walk in can't have the flu. They can't bring in live plants and things of that nature. High calorie, high protein, especially before they go in and have any kind of surgery, because they are going to need all of that extra protein and energy to heal and wound healing, because we already talked about it up here. What else can cause? So that's where we're at. If you look at the expected outcomes, well, the expected outcomes would be just the opposite of everything it said in the very front. It's going to focus on depending on the organ system itself, right? Collaboration. I touched it already with a diet, with increased amounts of calcium, a high calorie diet with calcium and vitamin D, certain kinds of foods. I don't know what ATI is going to have or what your NCLEX is going to have. Just know things. Glucocorticoid reduces both inflammation and immune response of immunity, increasing risk for infection. That's another one. So you start seeing how your patient is now at risk for all of these multiple things that we want to test you on. So, and there's nothing else. That's it. That was the end of, so we don't even talk about hyperaldosteronism. That was not there. Yeah. So that's all I have to pass at this point. So let me go ahead and stop sharing. I'm going to stop recording